Welcome everyone to the Canadian Nurses Association's webinar series, Progress and Practice. This webinar is on the dual public health emergencies, nursing at the intersections of COVID-19 and fentanyl poisoning crisis. This session is being recorded for nurses who are unable to participate today. My name is Aidan Hamza and I'm the lead for policy at the Canadian Nurses Association, and I will be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type into the Q&A box that you see to the right of the slide. We will address as many questions as time allows. The certificate of participation will be emailed to you along with the link to the recording of this webinar. And now a little bit about our presenters, Tali Cahill, Bryce Koch, and Corey Ranger. Tali has several years of experience working with and for people who use drugs. Currently, she is the nursing team lead for a primary care clinic and supervised consumption site in Ottawa, Ontario, and an MSN student at the University of Ottawa. Previously, she was a volunteer at the Overdose Prevention Ottawa's unsanctioned overdose prevention site and an inpatient medicine unit nurse at Ottawa Hospital. Bryce Koch is a registered nurse and student nurse practitioner. Before going back to school for his NP, Bryce was a public health nurse with the Healthy Sexuality and Harm Reduction team in Winnipeg. While in this position, he set up harm reduction supply distribution networks across Winnipeg. He is also the founder of Project Safe Audience, PSA. PSA is a harm reduction program that targets high-risk behaviors in the rave music festival population. PSA is Manitoba's only drug checking program. Corey Ranger is a registered nurse and clinical nurse lead for AVI and Solid's Victoria Safer Initiative. The Safer Initiative works to address the harms of an increasingly toxic drug supply by connecting individuals to pharmaceutical alternatives to the illegal drug supply. Corey has worked in harm reduction in Alberta and British Columbia and is an advocate for pragmatic public policy, safe supply, decriminalization, and an end to the war on drugs. Corey is a member of the board of directors for the HIV Legal Network and a regular contributor to the Urgent Public Health Needs Community of Practice Hub. Over to our presenters.
Thank you so much for that introduction, and hello, everybody. Before we get started today, I would like to recognize that colonization and the institutional oppressors that continue to permeate in our society have dramatically impacted Indigenous people who call this land home. The host of disproportionate impacts towards Indigenous peoples are far-reaching and span generations. There is a link between colonization, which is fundamentally a process of violence and disconnection that operates at multiple levels, both historically and today, and the topics we're here to discuss, namely the war on people who use drugs, and ultimately a land acknowledgement is not enough, not even remotely when it comes to eliminating structural and historical barriers erected through colonization. It is, however, a small step in committing to a relationship of humility and collaboration. It's with that spirit today that we acknowledge with respect the Lekwungen peoples whose traditional territory I stand on today, as well as the Songhees, Esquimalt, and Wassanic peoples whose historic relationship continue with this land today. We have continued to see disproportionate impacts, overdose, homelessness towards Indigenous people. And just last week here in our community here at Lekwungen territory, lost a young Indigenous woman on the Pandora block to overdose. And if there's anything that we need to get across today is that we can't talk about colonization as if it's something that happened in the past tense. It's something that continues to happen. It's something that continues to impact people. And it's important that we acknowledge that. Next slide. On behalf of all three of today's presenters, I also wanted to take a moment to acknowledge people with lived and living experience of criminalized drug use. They've borne the brunt of multiple public health crises, from innovating needle exchange programs at the height of the HIV/AIDS epidemic in Canada, to championing access to life-saving naloxone, to implementing supervised consumption services and overdose prevention sites in the face of losing their loved ones, friends, and communities. The work has come from people rising up and helping each other. This has happened in the absence of governments and institutions being able to act as quickly and effectively as they should have. Without the generosity of people with lived and living experience sharing their knowledge and expertise with folks like Bryce, Tali, and myself today, we wouldn't be able to be here talking to you about the programs we run or the lessons we've learned in our work. If you take one thing away from today's session, it is that there is a role for nurses in harm reduction, and it is working alongside people with lived and living experience, not as the saviors, but as allies uplifting the voices of those who are not afforded the power and privilege we all experience. Next slide. Just a little bit about myself. I started my nursing career in Alberta, and aside from a 2-year stint in the operating room and an on-again, off-again relationship with instructing, my entire career has revolved around harm reduction. I started this journey in Edmonton, facilitating bloodborne pathogens programs for folks experiencing homelessness. And upon completing this project, I went to Calgary working on the harm reduction team and in sexual health. My final years in Alberta have included implementing HIV programming in southern rural Alberta, take-home naloxone programming, and finally opening supervised consumption services in Medicine Hat. It was right about that time that everything changed for me when the Alberta government changed and we saw a complete shift in ideology, which prompted me to move back to British Columbia. Next slide. We're going to start off talking just about a high-level overview of what is going on with Overdose in Canada, and then I'm going to focus more specifically on what's happening in British Columbia. You're going to get the opportunity to hear from 3 harm reduction nurses who are working across Canada, who are going to talk about how COVID-19 has impacted the work that they do, and giving you some really important tips that you can take away from this webinar that you can apply to your daily practice, regardless of where that might be. Since January 2016 to September 2020, so a little under 5 years, 19,355 Canadians have died by fentanyl poisoning. Reporting on a national level is always slow to catch up because we have to wait for every province to submit their data. But you can be rest assured that the number is well above 20,000 now, and it's only getting worse. As we'll discuss shortly, COVID-19 has only exacerbated the harms of a toxic and volatile drug supply and heightened risk for people who use substances. In the 6 months following implementation of COVID-19 measures in Canada, there was a 74% increase in overdose deaths. The death toll is on the rise, and for many of us, we've been working at the pace of a public health emergency for years now. When the global pandemic inflamed risk, for many, it became completely untenable. As a stark contrast to COVID-19, which has disproportionately impacted older adults and people who are immune compromised, overdose has cut a clean swath through a younger generation in Canada. Overdose is in fact one of the leading causes of death for Canadians aged 30 to 39, and is the leading cause of death for males in that same age category. British Columbia, Alberta, and Ontario are among the most impacted by fentanyl poisoning, but the increase has been noted across the country. Next slide. So what's happening in British Columbia? Well, it's been about 5 years, April 14th, 2016, since British Columbia declared a public health emergency to responding to a surge in overdose deaths. And we're currently actually in the worst iteration of the overdose crisis. That should tell you something about the actions that have been taken to respond to overdose, the fact that we're 5 years into a declared public health emergency and we're only now at the worst stage. In February of 2021, we lost 155 people to overdose death. That averaged out to about 5.5 deaths every day in February of 2021. The drug supply continues to become increasingly contaminated. And in the first 2 months of 2021, carfentanil, an incredibly potent and toxic animal tranquilizer, was noted in the deaths of 31 people. And we have some resolutions to these issues, and one of them here in British Columbia is safe supply. But what we're currently experiencing is a significant amount of restricted access to safe supply. It's estimated that there's around 88,000 British Columbians who would benefit from accessing a safe supply, but only around 3,329 of them have been able to, which is a less than 4% accessibility rate. And just like I noted with the trends in ages across Canada, here in British Columbia, 69% of the people who are dying are aged 30 to 59. Next slide. So what's happening? How come COVID-19 has led to such a horrific increase in overdose deaths? The answer is a radical change in drug supply volatility. What caused that change? To answer that, we would have to examine the collateral impacts of COVID-19 from the macro to the individual level. First, we need to acknowledge that broader sweeping public health recommendations rarely address the specific context of harm reduction, low barrier, or shelter-like settings. When governments shutter services and tell folks to stay home, they aren't thinking about the people who have no home. When they tweet out that they won't leave anybody behind, they aren't talking about people who use drugs. So what happened? From the macro side of things, we saw border closures impact traditional drug supply routes. This created supply and demand issues, increasing drug volatility and forcing new manufacturers to get involved. Pre-pandemic concentrations of fentanyl on the street was around 8%, and that was already causing lots of harms for people. Now, drug testers are noting that fentanyl concentrations are around 24 to 32%. And most drugs are containing benzodiazepines and drugs like xylazine, which are animal tranquilizers and are toxic to humans. We also saw massive disruptions, restrictions, and closures of essential services. Even the organization I work for was no longer able to operate overdose prevention services because our space was so small and wasn't compliant with infection prevention and control. On an individual level, people were being told to isolate, socially distance, stay away. One of the biggest determining factors in overdose is isolation. And so when you combine all of these factors, what you have is a perfect storm. And frankly, many of us saw it coming. Then there's what we did to those who were made most vulnerable by an oppressive system. Next slide, please. As folks we blocked from accessing low barrier services here in Victoria and Vancouver, the cities actually directed people who were experiencing homelessness to shelter in place in state-run homeless encampments. And that's where I found myself at the beginning of the pandemic. Prior to the pandemic, I was working as a project manager for the Ministry of Mental Health and Addictions, running a peer training project, and I was volunteering in one of these parks, and then the risk just became so severe that I ended up taking a leave of absence and working full-time in the parks. Sadly, it took 7 days for us to get access to clean soap and water. It took 17 days to get access for showers. It took over 37 days for access to laundry. At one point in time, we had over 220 tents in the park. In April of last year, that's when we started to see the changes in the drug supply, and the overdoses started happening all around us. In 1 week last April, I responded to 28 overdoses, and 7 of them were on a Sunday afternoon. It wasn't until people died in the encampments that the government decided to offer temporary shelters in hotels, and even that wasn't done safely. Instead of leading with support, the province framed the move to hotels as a public safety initiative and leaned on law enforcement to decamp shelters. They erected fences around tents, destroyed people's property, and forced them into hotel rooms without insufficient supports available. And again, more people died. Next slide. Enter safe supply. So another thing happened last year in April, and the province decided to finally support the upscaling of safe supply. And what safe supply is access to pharmaceutical alternatives to the toxic drug supply. So in April of 2020, they released this document that would support prescribers to prescribe people pharmaceutical alternatives so that they wouldn't be taking street drugs that were contaminated with excessive levels of fentanyl, carfentanil, or benzodiazepines. Shortly afterwards, the organization that I work for gained funding to start a safe supply initiative, and that is the Victoria Safer Initiative. We work with a group of people with lived and living experience, or peers, nurses, systems navigators, and physicians. And we connect mostly with people who are left unhoused during the pandemic. So the 200 to 300 people who are sleeping rough outside in parks right now in Victoria are our main population that we work with. We connect with them, we assess risk, we do a full intake and assessment, and then we connect with a prescriber who writes a prescription for pharmaceutical alternatives. But it's a little bit more complicated than that because many of the folks that we work with experience significant barriers. So we help them gain access to their ID, their birth certificate. We complete their blood work out in the parks. We do their full primary care assessments, referrals, and we've actually been able to put out quite a positive amount of benefits in a short amount of time. We were given 10 months of funding to develop a flexible harm reduction model for safe supply. And during that time, we've connected over 120 people to safe supply. We have an active caseload of 77 people right now. And from that, we have had folks who have completely stopped using street down. We have 0 overdose deaths among the folks that we've worked with. And most importantly, a large amount of people have reported reduced use of illegal substances, safer use practices, decreased cravings, decreased withdrawal symptoms, healed wounds, improved mental health, increased connection to healthcare, less reliance on the street economy, and improved overall function. We have a lot of work to do, however, because safe supply simply is not accessible for folks in BC. Even if you're working with 120 people, that's nothing compared to the 88,000 who could benefit from an initiative like this. Next slide. So what can I tell you? What 5 lessons can I share with you today before I pass on over to Bryce and Tali? The first is that as a nurse, you have to understand and challenge power structures. There's a significant amount of power imbalance that exists between you and the patient, but also between you and the system and between you and physicians. Understanding those power structures and knowing when to challenge them is one of the most important parts of advocating as a nurse, especially when you're talking about some of these more controversial or newer initiatives that require a lot of advocacy to get by it. The next is that it's really important that we're making sure that we're holding space and uplifting others. Harm reduction is the radical redistribution of power and resources to those less privileged. If you understand and challenge power structures, then you will understand how holding space is so important. People with lived and living experience are the innovators in this crisis, and many others. They assume risk when powerful institutions dither in their responses. They also continue to be tokenized, stigmatized, and ignored on critical issues. Holding space means that what we have is a platform, and that we need to find a way to uplift and use our privilege to make sure that other people can have a voice at the table. The next is to avoid performative allyship. It's really easy to tweet. It's really easy to show up at a protest and hold a sign. It's actually not even that difficult to give a presentation to a group of nurses like we're doing right now. But what's more difficult and more important is direct action. What can you do right now within your capacity? The next lesson is to learn to use your strengths, which is your presence and your objectivity. One of my most powerful advocacy tools when working in the homeless encampments was simply the fact that I was there. So I could tell people what the harms were of bad policy. I could report on what I was observing, and I was able to challenge some policymakers who were very disconnected from the system. And finally, the last tip, know and uplift the evidence. Get informed, learn about drug policy, learn about colonization, and find ways to challenge some of the really entrenched power structures that exist. Last slide. And finally, make sure that you learn about the principles of anti-oppressive practices. There's a lot of stigma embedded within nursing. There's a lot of paternalism that exists between nurses and physicians and patients. Understand even the power of the language that you use and challenge when you hear people use stigmatizing terms. Thank you very much.
So hi everybody, and thanks Corey. That was a lot of stuff, and I have way fewer slides because I think Corey, said a lot of great things and a lot of things that we all agree with. So my name is Tali. I am the clinical lead of a primary care clinic and supervised consumption site in downtown Ottawa on the unceded and traditional territory of the Algonquin Anishinaabe people. And I'm also a master's student at the University of Ottawa, and I'm focusing on my research on harm reduction in hospitals and methadone, Suboxone, and overdoses. And here you'll see just our little community health center and the supervised consumption site. Looking at about 75% of it right there. It's kind of a small room. And that's where I work every day. You can go to the next slide. So, I only have a few slides, and this is probably the most important one. And basically, it's showing you how many people are dying in Ontario right now. And, the full picture hasn't been released yet. I've seen the preliminary numbers, but we're looking at a consistent 60% increase in fatal overdoses, so fatal poisonings, in 2020 compared to the same period in 2019. It evens out to about 7 people a day dying from poisoning in Ontario. And it's often young men and mostly people who are using alone. And that is consistent with what we've been seeing across the country, where people are using alone, they're isolating, they're trying to stay safe from COVID, but it's really hard because that using alone is risky if there's no one there to save you with naloxone, just because of the drug supply being so inconsistent and being so just not only strong, but inconsistent day to day. So sometimes it's strong, sometimes it's weak. People have no idea what they're getting at any different time, and they don't know exactly how much to use. And what's interesting is what we've seen over the course of the last year during the pandemic is an increase in substance use overall. including alcohol, including cannabis. I know the most recent lockdown in Ontario, there's a line like 3 blocks long to get into the LCBO at the beginning of that lockdown. And so people use substances to cope with difficult circumstances. That is normal, that is human, that is rational. What is tragic is that people who use opioids or use street drugs during the pandemic don't have a consistent supply like people who use alcohol or cannabis. And that is what is killing people. And it's just amazing. 2017, only 15, I think it was not only, but 1,519 people died of overdose. And so now it's going to be thousands of people died of poisoning in Ontario in 2020. You go to the next slide. So Corey said a lot of things about the drug supply and a lot of really great tips of what you can do in terms of challenging power in your practice. I'm going to give you some practical things because I think that people often come to me and they think that, okay, you work with people who use drugs, that's your job. I'm a nurse, I'm in a separate field. You do your thing. I don't have anything to do with that. And that's actually not true because substance use touches every single field of nursing, whether you work in an OR, whether you work in a NICU, whether you're a primary care nurse, whether you work with the elderly, people use substances. It is a universal human truth. You're going to see it, and you need to know how to work with people who use drugs, and you need to know how to examine your prejudices and beliefs before you go into work. So one thing that's really important to do is carry naloxone with you when you're walking around so you can help save someone's life. Another thing that's really important is using person-centered language and challenging the stigma that you have about substance use and people who use drugs. And I definitely remember being in the hospital and hearing nurses talk about, you know, those people using terms like junkies, using things like, well, that person did that to themselves versus someone with cancer who didn't choose to have something horrible happen to them. And you need to really get rid of that language. Our patients hear that. They know how you feel. And although nurses are really trusted as a profession, I will say that people who use drugs don't necessarily trust us because of the treatment they received in the hospital. People need to have their pain assessed and treated. If you're leaving in the hospital in withdrawal, you're leaving at risk of overdose. And so you need to assess your patients and make sure that they are being taken care of while they're there and when they leave, because it can be a deadly time if they're leaving with a lower tolerance than they came to the hospital with. Advocate for methadone, Suboxone, Cadian in any practice that you have, whether it's corrections, whether you're in the hospital, whether you're in primary care. Know about those treatments. That's the gold standard treatment for substance use, for opiate use. And really be careful about talking about people going to rehab or quitting cold turkey. It's actually quite dangerous for people who use opioids to do that, to just quit like that. We know that it can kill people. So when we're talking about that as a treatment that people just need to quit, you're not talking from a place of knowledge. You're not talking, this isn't evidence-based. It does work for some people. There are anecdotal reports that it works, but really the gold standard is that people need to have they need to use opioids in order to stay safe from overdose. And it's important for you to know that in your practice. And ask about your practice settings policies towards people who use drugs and harm reduction. Challenge your practice setting if they don't have those policies, if your hospital doesn't have clean equipment to give out, if you're, if you don't have any physicians who are, or NPs who are prescribing Suboxone in your primary care clinic. Let's make it accessible, all of our practice settings accessible for people who use drugs. And advocate for change on a greater basis. So in Ontario, we don't really have much action on the overdose crisis, unfortunately. Like COVID has really taken a lot of people's time and energy, and it's so important that we get over this pandemic, but there's this whole public health crisis that's been happening for years, and there's not much talk about it. And what we have to do is keep it in the conversation and keep politicians, answering to what we are advocating for our patients. And that's all of our jobs as patient advocates, as nurses. That's it. Next slide.
Awesome. Thank you very much, Tali and Corey, for starting us off there. So yeah, my name is Bryce Koch, and I'm going to start this off with my own personal land acknowledgement. So I'm a settler on Treaty 1 territory. This land was stolen from the Anishinaabe, Cree, Ojibwe Cree, Dakota, and Dene peoples, and it's also the homeland of the Métis Nation. My ancestors came to Canada from Ukraine and settled on Porcupine Plain, Saskatchewan, which is located within the traditional territories of the Anishinaabe and Cree people, as well as the territory of Treaty 6. My family was supported by the Indigenous population of Porcupine Plains, and I doubt I'd be here if it wasn't for their generosity and support and guidance. As a settler, I acknowledge the harms done by my ancestors and also acknowledge that these same harms are still negatively affecting the Indigenous populations who live on these lands today. I strive towards reconciliation within my own professional practice and daily life by doing my part to dismantle and abolish the racist and oppressive systems that continue to uphold settler colonial ideologies and values. I think it's important that we all sort of take time to reflect and understand what our relationship to the land is and who were the original carekeepers of this land. So I suggest all of you at some point in your day and some point in your life is sit around and think about it. What is your relationship to this land? Might have some good self-reflection. So yeah, my name is Bryce Koch. I got my career started in nursing, working in emergency medicine. I did that for a couple of years and decided to switch over to the complete opposite side of the spectrum and had some fun in public health, where I worked as a public health nurse with the Healthy Sexuality and Harm Reduction team in Winnipeg, Manitoba. I am the director of an organization called Project Safe Audience, which is a harm reduction initiative that targets high-risk behaviors in the rave and music festival population. We go to music festivals and parties and provide on-site drug testing, some mental health crisis intervention, and harm reduction supply distribution. In addition to that, I'm the regional representative for Central Canada for the Harm Reduction Nurses Association, and also I am a student nurse practitioner at the University of Manitoba. Next slide. So just a little bit of some background on what things are going on in my neck of the woods. So in Manitoba, we predominantly have a stimulant using population. However, that is beginning to change, and that actually started changing at the start of the COVID pandemic. Opiate use and ODs are on the rise. And what we noticed is right around last year, right when the COVID first started taking off, we noticed a pretty significant change in the cost of stimulants within our province. So in the matter of about 2 to 3 weeks, the price of meth went from around $10 a point up to about $50 to $60 a point. And so a point's about 100 milligrams. And so, yeah, that significant increase of cost destabilized our drug supply and made it more and more toxic. Around that time, we started noticing a pretty significant increase in opiate ODs as people were switching over to using opiates. Also, the opiate supply started becoming more unstable. We started seeing very large, very different percentages of fentanyl concentration. Like Corey mentioned, we were seeing low 5-10% sort of stuff on some of the stuff we got sent off for testing. And then, we're also seeing stuff around 25 to 30% fentanyl by weight for some of the stuff we got sent off for testing. So that significant change in concentration really made the supply more toxic, and, people weren't able to actually properly dose the medicine that they need. So we got some stats here, and you may notice that I have some limited stats, and there is a reason for that. So in 2020, we had 372 overdose deaths. This was about an 87% increase from 2019. In that same time period, we also noticed a 33% increase in naloxone use by paramedics. So yeah, one of the unfortunate things about Manitoba is our provincial government is not supportive of harm reduction and has made it extremely difficult to provide harm reduction information, harm reduction programming to the people of our province. Next slide. And this kind of leads me to my next slide here. Health is political, sadly. Our province doesn't really release any overdose data. The data that I had there was actually acquired using an FIPPA request to actually get that info released. About 2 to 3 years ago, we stopped receiving overdose numbers, and in some of the overdose papers that have been released nationally, there's a little bullet at the bottom that says like Manitoba was not included because we didn't have any overdose numbers. So that made it really difficult to actually provide services in this province because we didn't actually have any good data on what was going on. In addition to that, our province has also blocked certain harm reduction practices, such as safe consumption spaces and drug checking. I've been a part of numerous programs where we've had to stop what we were doing directly because we couldn't get approval from our provincial government, which is now leading to more activist movements around getting these services up and running without support of the province. And this kind of leads into my kind of first suggestion for nurses is, get involved in advocating for the government. With these fancy letters that we have behind our name, RNBN, you can easily pull up meetings with members of parliament as well as other people in the political system. And with that, what we can do, we can use that sort of privilege that we have to help advocate from that angle. One thing that I do in my practice is what I will use that RN designation to help get peers in front of policy makers. So when I set up meetings with different policy makers, I will bring peers with me because they are really the ones who are leading the care of this overdose crisis that we're in, and so they're the ones who really should be suggesting changes and really be moving policy changes. So using that designation to open doors for peers and people who use drugs to advocate for the change that they need to keep themselves safe. Next slide. So yeah, and this has been mentioned by Corey and Tali, is we need to open up space for peers. So healthcare, including nurses, we should not be leading harm reduction. We can be supportive of all this, but peers and people with lived experience and living experience around substance use are the ones who really should be leading this moment. They're the ones with the experience in this. These are the people who this has been a lifestyle for them. And nurses and healthcare kind of gets a bit of a savior complex when they get too heavily involved in things. And so we need to help peers and peer groups reach the goals that they want to reach. So what we can do is by offering logistics supports to any peer groups. So offering to help with organization, or helping them get in front of policymakers, or offering letters of support for funding opportunities. That can go a long way for getting these peer groups up and running and supporting them. Like I mentioned a couple times, help get them in front of policymakers. We have a lot of privileges, nurses. We can use this to help better this population. So what we can do is use that privilege and help get these peers in front of policymakers. And yeah, I've already mentioned a couple times is, use that privilege there. Get these peers up in front of policymakers and let them be the voice of change that they need. Next slide. All right, challenging the norm. So old policy caused harm to people who use drugs, and I got a pretty sad story I want to share. So when I used to work in the ER, and this was early on in my nursing career, we had a client come in of a suspected overdose. The physician at the time patted him down, found a baggie of substances, and then took that baggie of substances and threw it in the trash. And when asked why he did that, he told me that's like, oh, this will prevent him from overdosing again. Well, by the end of my shift, that individual had been released and went back out in the community. And what we had found out the next day is that he ended up having to look for other substances and ended up overdosing and passing away. And this was, in my opinion, this was directly related because we took his supply of substances. And when I talked to the physician later, he told me that that was just how we do things. So yeah, challenge these policies that cause harm to people who use drugs. Criminalization of substance use has caused uncalculable amount of harms to people who use substance. It has made this drug supply extremely toxic. It has made it unstable, and we need to change our policies around that. We can't be trying to change a medical problem by using a criminal system. Challenge abstinent-focused or abstinent-based policies and programs. In Manitoba, a lot of our supportive programs are abstinent-based, and actually there is the majority of shelters in our province cannot be accessed by people who use substances, that you will be turned away even in the coldest months if you are using substance. And I think having policies where you need to be sober to access services are ridiculous. It's some people, when they use that medicine to get them through their day, and there may not be a time when they are sober. So we're really doing them a disservice by preventing them access just because of intoxication. Just because this has always been the way we do things doesn't mean it's the right way. There can be better ways. We can be better. We can be a better supportive support to people who use substances. Next slide. And a little bit looking internal now and talking about nurses who use substances. So might be a surprise to some people, but nurses are humans. And we actually have about the same rates of substance use as the general population. And that means we are also susceptible to developing problematic substance use. And that's something I've noticed a little bit since COVID started. I've had many colleagues come talk to me about their substance use and noticing that they are increasing their substance use due to the stress and horrible working conditions that we're currently experiencing in this pandemic. And so to support nurses who use substances, the Harm Reduction Nurses Association actually put out a position statement about supporting nurses who use substances. And I have a couple of quotes from there. Nurses often use substances to cope with pain, stress, and trauma of working in healthcare. If they develop problematic substance use as a result of the system failing to provide them with safe and decent working conditions, they should not be punished for it. Next slide. One of the sad things is we are punished for substance use. Nurses who use substances are forced into programs that in many cases are not evidence-based and may be religious-based. I know of one individual in particular who tried to get some support for their substance use, and his college ended up finding out and forced him into a 12-step program that was religious-based, even though that didn't resonate with him at all. And that can cause more trauma and actually can prevent healing from that situation. So the most concerning is the fact that nurses with problematic substance use are not afforded the same rights as other citizens, are mandated to undergo prolonged and standardized treatments programs which are not evidence-based and are forced into an expensive and ethically questionable system of surveillance and reporting. We provide, within nursing, we provide harm reduction resources and teachings to people, but we don't provide that to ourselves. And I think that's hugely problematic. We are failing our colleagues here by forcing them into these programs. Next slide. If you want to read that position statement, you can find it on our website at www.hrna-airrm.ca. And this is a quick little plug about the Harm Reduction Nurses Association. So the Harm Reduction Nurses Association, our mission is to promote the advancement of harm reduction nursing through practice, education, research, and advocacy. And then we have our mission statement before that. If anything in this presentation resonated with you, or you're looking for more information about how you can incorporate harm reduction practices into your nursing practice, I strongly recommend you sign up for membership with the HRNA. We have a membership portal with many resources from across Canada that can help support you in your learning needs, including webinars, policies, and other documents that you may find useful in promoting harm reduction practices within your workspace or even within your own life. So yeah, if you have the time, I'd strongly recommend you sign up to be a member. And that's it from me. I guess next slide.
A big thank you to all three of you for such a great, engaging, and insightful presentation. Before we move on to the Q&A period, we'd just like to ask participants to answer a couple poll questions about today's webinar. And now we'll start the discussion portion of the webinar. So if you haven't already, please type your questions into the Q&A text box. And I know we have one there and we also have one in the chat. So I'm just going to start with the one here in the chat. It's asking specifically, do we have any race-based data available for the numbers that you've presented? I know all three of you presented numbers for different areas. This is particularly because the participant lives in Northern Ontario and they know that Indigenous people are disproportionately affected.
Yeah, we have, we don't have great race-based data on a lot of things. I mean, COVID-19 is a really good example of how we don't really collect that data in a meaningful and accurate way. We do know that absolutely Indigenous people are disproportionately affected. When I saw that question, I tried to look up and get kind of a sense. In the latest coroner's report for Ontario, it has it more kind of, what they do is they identified ethnically diverse neighborhoods. Because the data for each death, the race-based data isn't collected in I think a consistent way. So we do know that those neighborhoods that are identified as being ethnoculturally diverse are disproportionately affected. And then for data in previous years, definitely for the overdose crisis, I've seen anything for Indigenous deaths to 3 to 4 rates, 3 to 4 times the rate of the deaths of white people in Canada. So absolutely, they are disproportionately affected, and I think Corey spoke to that, and the history of colonization and stigma, and also just access to healthcare in general for Indigenous people, especially in the North, that their access to healthcare and especially opiate agonist treatment, therapy, stuff like that is kind of limited because their whole access to healthcare is limited, as you probably know. So they're of course going to be disproportionately affected in terms of deaths if they can't access the treatment that they need.
From a British Columbia standpoint, the First Nations Health Authority puts out some pretty regular data, and despite the fact that Indigenous folks, people who identify as First Nations, make up 3.4% of the population in BC. About 14% of all overdose events involve people who identify as First Nations, and about 10% of all overdose deaths involve First Nations people. So that is textbook a disproportionate impact.
So within Manitoba, we don't really have great data on overdose deaths, but I can say from working in frontline work that Indigenous people are disproportionately affected by this overdose and poisoning crisis that we're currently in. But like I said in my sections through there, we don't exactly have great numbers here in Manitoba, so I don't really have anything solid to share.
I think that also speaks to just the COVID-19. One of the things that strikes me all the time, and I talk about this a lot, is that we have like dashboards for COVID-19. So we know we don't have great race-based data, but we do know exactly who's dying. Like I get an email every day of how many people, how many cases in the world, how many people have died in Ottawa, all of these things, who's in the ICU. We don't have that data for overdose deaths in a timely manner or even at all in Canada. And so it's I won't get the final numbers for Ontario until the end of May. And when you think about the tremendous effort that's being brought forward to bring forward that information for COVID-19, it's just tragic to me that we can't even put a percentage of that effort into getting just data on overdose deaths here in Canada.
Well, and that's one of the things that's frustrating here. Like this data is being collected, like the data lives somewhere, but it's just not being released, which is just extremely frustrating.
Yeah, absolutely. I definitely see the overlap there with the COVID-19 data challenges as well. We have another question here from the Q&A. Specifically, to Corey, how did you move ahead with safe supply? We have the participants saying that they had to go to court with their government to keep their IOAT clinics open short term, and they're not sure how they can move ahead to safe supply in Alberta. So I don't know if you can share any practical tips.
Yeah, I mean, you're up against the wall in Alberta, and I can totally empathize with what's happening here. I am the former clinical lead of the first supervised consumption service that was shut down by the UCP government. And I, have been working with on an advocacy front about the IO programs and the lawsuit that happened over that. And it's just really tragic what's happened there. How did we move forward with safe supply in BC? Well, the BC Center on Substance Use, along with the Ministry of Mental Health and Addictions, actually utilized COVID as an opportunity to get safe supply in BC. They originally rolled out safe supply as a mitigation effort for COVID-19, meaning that they were trying to support people to isolate in place in case they started to go through withdrawal and weren't able to access their regular supply of drugs. and how did I personally advocate for it? The second that the government made that available, we were working in the parks and we started phoning doctors and asking them which of you would be willing to prescribe a safe supply, educating physicians, educating service providers, and eventually we gathered together a cohort of doctors who were willing to do this work. And then when we received funding to start our safe supply program, we actually held on to that same cohort of doctors and we brought them over to us. And so we have a really, really great pragmatic group of physicians who trust their nurses and trust the peers to do the assessments and the intakes and to advocate for people to gain access to pharmaceutical alternatives. So the long and the short of it is that, we are able to do this work here in BC because we have a government that's trying at least to enable access to safe supply. They're not doing the greatest job, and there is so much inequity when it comes to accessibility, but that pales in comparison to what you're up against in Alberta. So continue to advocate for harm reduction in Alberta, continue to advocate for safe supply. You guys just lost another supervised consumption service in Edmonton, which is horrible and tragic, and is going to lead to more preventable deaths. But there is power that you have, and you need to make sure that you're speaking up on behalf of the Albertans that don't have a voice, because it's getting really dire there.
Thank you there, Corey, for that insight. The next question, I guess, would be to all of you is, how can I access a list of evidence-based recovery programs? Is this available on the harm reduction site? And then as a follow-up, are there any recovery centers, if there's a recovery center that is developing a new recovery program, how do you go about getting that evaluated so that it meets the criteria for evidence-based practice?
Well, that's a really good question, because I don't know if there is such a list. I mean, I think that the thing when we talk about recovery, and Bryce and Corey can chime in on this, but like people, that means a lot of different things to a lot of people. I think that I personally, really abstinence-based treatment, and by this I mean treatment that doesn't offer some kind of opiate agonist therapy, it's not very safe. And so I would be calling up places. If I were sending a loved one, I would make sure that they don't try to take people off of their methadone or Suboxone, or they don't try to taper them down rapidly. So really finding treatment places where people can access those medications are really important. And I'm not sure if there is a list, and I'm not sure also if unfortunately, recovery and treatment places aren't regulated a ton. And so it's really hard to tell exactly what is going on there and which ones are quality and which ones aren't. And sometimes residential treatment doesn't work for everybody either. So we talk about that as being something that everyone just goes and gets sent and it fixes them up and they come back. And that's not really, it works for some people, but it's not overall on a population-wide basis like a super successful strategy for recovery.
Yeah, I would kind of say similar things as Tali there. If you're going for recovery services, look for something that is helping people gain better control over their substance use, not requiring them to remove all of it from their life rapidly. Trying to remove all substances all at once can be challenging for people and can lead to some pretty unsafe practices. I am unaware of any list of any recovery programs that would kind of fit that criteria. But yeah, looking for places that help people gain better control over their substance use rather than requiring complete abstinence from it.
And I think as nurses, we have the ability to challenge some of the antiquated policies that exist within treatment and withdrawal management services, detox services. There's a lot of outdated rhetoric that's embedded within addiction medicine, and it revolves around paternalism and control. And that comes from doctors and nurses who think that they know what's best for a patient, when in reality, it's about what their patient actually wants and what their priorities are. And it's the core tenements of person-centered care. And so every treatment facility, recovery facility, whether they buy into a harm reduction philosophy or not, has room for improvement. Because what we know too is oftentimes people access these services and then they relapse and they're kicked out because there's a zero tolerance policy, and they overdose shortly afterwards because all we've done is drop their tolerance over the time that they were accessing those services. So I don't have a specific list, but I definitely know that when I'm referring people to recovery services, I ask them about what their policies are. If people relapse, what happens if, you know, someone doesn't fit behavioral requirements that are often really arbitrary. What are the requirements when you're sending someone to a facility? Make sure that the person is informed so that you're setting them up not for failure, but for an opportunity to actually navigate those systems.
Thank you, everyone. Those are great strategies. And I particularly like the idea of, you know, nurses using the power that we have in the system to advocate and elevate the voices of patients. There's another question here related to nurses. Bryce, how can we advocate nationally for safer and better support and treatment for nurses experiencing problematic substance use?
So my suggestion would actually kind of bring it back from nationally and go provincially. Go towards your licensing body, because those are the people who actually are mandating you to go through these treatment programs. So in the province of Manitoba, that's the CRNM. And so asking them, what is your policy around nurses who use substances? What programs do you require them to be a part of to maintain their license or receive treatment? And so to start there, kind of get an idea of what nurses who use substances go through when they have to, when they're required to go for treatment because of their substance use by the registered college. And so, yeah, get your start there. There's also, I know I was hooked up with some people locally who had to go through the treatment program, and they vocalized a lot of concerns by what they were forced to go through. And so trying to connect with those people, try to find out where they are and see if there's anything that that they experienced that was problematic for them going through their treatment, and kind of starting there. I think this is more of a provincial issue, case by case for provincially, as opposed to sort of a national thing, because it's your provincial body that is controlling your license.
That actually is a great lead into the next question, which is, I guess, challenging that provincial territorial federal relationship, asking why isn't there, I guess, if I were to paraphrase, why is there not a federal program similar as there was, recognizing that with cannabis, there was a shift in the political will. Could there be something similar at the federal level to support this program? Oh, I see you laughing there, Tali.
Well, I mean, yeah, that would be great. That would be, and I think I've been thinking about this a lot, because I think the thing is with cannabis, it was not only politicians, but people on the ground making that request and wanting that change and advocating for it. And honestly, you know, there are many solutions to this crisis, but a huge one is decriminalization and provision of like legalized regulated substances. I'm sure we would all agree on this panel about that, and that's one of the huge solutions to this. And we won't get there unless the average person advocates politically for that solution, because it's controversial. People don't really understand how drug prohibition makes things worse and how much money we're wasting on it. And so if all of you nurses who are watching this, like, advocate to your MP, advocate to your MPPs about just keep on talking about decriminalization, keep normalizing it. I think that's something that we could all do, because they're not going to do it without people asking for it. It's just, it hasn't been, we talk about it, but it never seems to happen.
Thanks so much. We have another question here coming from the chat and asking, can someone speak to the impact of benzodiazepine contamination? They've seen that Vancouver has certainly seen this and how it affects people's access to withdrawal management, as well as overdoses and the day-to-day life and safety.
Yeah, I'm happy to touch on that. The increasing volatility of the drug supply has actually made most harm reduction work more challenging. Even the provision of a safe supply, we can, you know, people's tolerances are starting to outpace what we're able to offer them. Pre-pandemic, we were noticing people telling us that they were using around 1 to 2 points a day, and now they're telling us frequently that they're using a half ball to a ball a day, and that's a significant increase in the amount that they're using. But what they're using is also higher concentrations of fentanyl and containing benzodiazepines. And so the drugs that we have available to offer people aren't as effective, because people now who are accessing street drugs are accessing fentanyl regularly. There is no heroin out there. Everyone who thinks they're getting heroin is actually getting fentanyl. And so when they access withdrawal management services and they start to experience withdrawal from opioids, they may also start to experience withdrawal from benzodiazepines, which is a much more serious type of withdrawal and can honestly cause some pretty concerning health-related issues. And so even if we offer someone an opioid alternative and they stop using street drugs, they could start to go through benzo withdrawal without us being able to catch that in time. And so it's making things way more complicated. It's also making overdose response more complicated because we know that naloxone doesn't work on benzodiazepines. And so we're having a lot of really prolonged overdoses that we're responding to where we administer naloxone and they're still not waking up. Their breathing still isn't sufficient. We're having to support them with oxygen or just rouse them on a regular basis. And it's lasting hours. It's lasting shift changes in the OPSs where we're still monitoring people. And with the benzos, they also have, a prolonged amnesic effect where they don't remember what happened. They might want to use again. And that risk period is just really heightened while they're going through that whole experience. So yeah, it's incredibly challenging.
One thing we kind of noticed here in Manitoba, it was sort of around the same time that COVID all started. We were hearing reports from peers that there was some Narcan-resistant fentanyl that was going around there, and so we were getting test results from BC and Ontario, both showing that there were benzodiazepines in the down supply. So we were suspecting that so that's probably what we're experiencing here, and so we've actually just recently. We're able to get a sample sent off to BC for testing that actually came back positive for atizolam, which is a benzodiazepine. And so we suspect it's been a part of this for at least the last couple of years or so, at least since COVID started at the very least. But yeah, we've had to change how we distribute Narcan because of that. So we were originally just distributing 1 kit per person, but we've ended up going up to 2 kits per person, just because we noticed that people aren't getting out of their overdoses as quickly as they were before, and they're sometimes requiring like 2, 3, 4, 5 ampules of Narcan if you're dealing with that overdose within the community setting. And I think that's partially related to the fact that we have this toxic drug supply that is cut with benzodiazepines.
Thank you guys for those kind of great insights there. Now a question related to people as educators. What can educators be doing better to educate and prepare our nursing students to effectively care for those with substance use disorders?
One policy that the Harm Reduction Nurses Association released was actually around how we should be increasing harm reduction education in BN nursing programs. So I'll post that into the chat there. So this is our position statement on using or increasing the amount of harm reduction teaching within BN nursing programs. And so that can give you some suggestions on where your work can increase to help support harm reduction practices in new nurses.
You know what's wild, and people don't even know this, but in Ontario, like harm reduction is one of the entry to practice competencies for new nurses, and yet there's no specific education about that. So I mean, I think that the question is great. It's actually a requirement for practice in Ontario that we know about harm reduction, and so everyone needs to be incorporating it into their practice and into educating new nurses.
And I think I'm coming up on the last question here. We only have a couple minutes left. And specifically, it's related to their experiences of seeing younger people in Victoria and Vancouver dying as a result of fentanyl. And asking what are the signs that teenagers or youth are using drugs or using substances. I'm assuming this is from the nursing perspective. What should nurses be looking out for when their clients come in, when they're seeing patients in different settings, young people?
Yeah, I mean, this might be an oversimplified answer, but don't make assumptions, because lots of people use drugs, and that includes tons and tons of youth. And really normalize the fact that people use drugs, and that's okay, and that's not the problem here. Let's just find out how we can do this safely. With youth, it's so much about trust and relationship and how you come at people. And I recall my very first experience working in harm reduction, and I was working in Edmonton, and our employer put us through a values test and asked us, how comfortable would you be working with a youth who was injecting drugs? And at the time I was like, oh, 100% super comfortable doing that kind of work. And then that same day, a youth came in to access sterile supplies for injection drug use. And I felt this bit of discomfort. But instead of saying, no, I'm sorry, I'm not comfortable with that, you're a youth, we sat down and we talked about what they were going to use, why they were planning on using, and how they can do it safely. And in the time that we spent together, we were able to connect this person to a doctor and gain them access to supports. We still gave them sterile supplies to use, because the truth is that if we didn't, they were still going to use, but they might have ended up sharing something or using in isolation. And not providing those services doesn't mean that you're going to stop that youth from using. Instead, we just need to make sure we're meeting them where they're at.
Absolutely. Thank you, all three of you, for such a great presentation and for really such a great discussion for nurses. We hope that this session for all of the participants helped stimulate your thinking around the current dual health emergencies. And I know we still have some questions in the chat and in the Q&A, and maybe we'll have an opportunity to forward some of those questions to the presenters after the webinar is closed. Also, the links that have been provided in the chat box, we can send out to all the participants afterwards as well. You can access recordings of our webinars by visiting CNA's YouTube channel as well. And stay tuned, as the next CNA webinar will be announced shortly. Thank you again, Tali, Corey, and Bryce. I really appreciate it. And thanks everyone for joining in today.
Thanks everyone.
Thanks for having us.